This is AP Psychology, Chapter 17, Therapy. Mental health therapies include psychological therapies and biomedical therapies. Therapists using an eclectic approach draw from a variety of techniques. In fact, half of all psychotherapists describe themselves as taking an eclectic approach. Psychotherapy integration attempts to combine selection of assorted techniques into a single coherent system. Psychoanalysts use free association and interpretation of dreams, resistances, and transference to help their patients gain insight into unconscious origins of their disorders and to work through the accompanying feelings. Humanistic therapy focuses on clients' conscious feelings and their taking responsibility for their own growth. Client-centered therapists use active listening to express genuineness, acceptance, and empathy. Behavior therapists emphasize the direct modification of problem behaviors. They use exposure therapies such as systematic desensitization, aversive conditioning, and they may also apply operant conditioning principles with techniques such as token economies. Cognitive therapies aim to change self-defeating thinking by training people to view themselves in a new, more positive ways. Cognitive behavior therapies aim to change the way people act as alter the way they think. Except for traditional psychoanalysis, these various types of therapies may also occur in therapist-led small groups. One special type of group therapy, family therapy, assumes that no person is an island. Research on effectiveness of therapy indicates that people who receive therapy are more likely to improve than the untreated. However, the friendly council of paraprofessionals also tends to produce more improvement than occurs with untreated people. Administration of antipsychotic, anti-anxiety, and antidepressant drugs and mood-stabilizing medications constitutes the most widely used biomedical therapy. Electro-Convulsive Therapy, although controversial, continues to be an effective treatment for many severely depressed people who do not respond to drug therapy. Gentler alternatives to ECT are now being used. Psychosurgery is rarely used to alleviate specific problems, largely because the effects are irreversible and potentially drastic. Preventive mental health experts aim to change oppressive, esteem-destroying environments into more benevolent, nurturing environments that foster individual growth and self-confidence. The Psychosocial Approach recognizes the effective treatment of psychological disorders must consider biological and sociocultural factors. Maltreatment of insane people throughout the ages was the result of irrational views. Many patients were subjected to strange, debilitating treatments, and some of these were just downright dangerous. Philippe Finel of France and Dorothea Dix in America founded the humane movements to care for the mentally ill. Psychotherapy involves the emotionally charged, confiding interaction between a trained therapist and a mental patient. Biomedical therapy uses drugs or other procedures that act on a patient's nervous system, curing him or her of psychological disorders. An eclectic approach uses various forms of healing techniques depending on the client's unique problems. In Chapter 16, we reported Ronald Kessler and his colleagues' recent survey of the prevalence of psychological disorder. In their assessment of representative sample of 9,202 Americans, they also sought to determine whether people who suffer psychological disorders are receiving adequate treatment. Their study suggested that only a third of patients receive adequate treatment. Treatments were considered effective if there was evidence that they led to significant improvement. A total of 41% of those with the disorder actually sought treatment in the past year. This rate is significantly higher than the 25% who obtained treatment a decade ago, or the 19% who treated 2 decades ago. About a third of all visits for mental illness are to alternative practitioners, such as herbalists and chiropractors, whose interventions show little evidence of effectiveness. About 2 of every 5 visits are to mental health specialty who is not a psychiatrist, a psychologist, marriage counselor, social worker, etc. These people do best at offering well-established treatments. Those least likely to receive care are elderly, racial minority. Those least likely to receive care are the elderly, racial minorities, and rural residents. On the other hand of the continuum are the disproportionately affluent. Nearly a third of the visits for mental health care are made by people who don't have a disorder. Maybe they're nipping things in the bud, said Kessler. We just don't know. Men don't seek care as quickly as white women. How long do people wait to go for treatment? If they have symptoms of a mental disorder, the average delay is a decade. The sooner in life an illness begins, the longer the delay and more persistent the disorder. Delay also depends on the specific disorder. Average time of delay for bipolar disorder is 6 years. For generalized anxiety disorder, it's 9 years. For attention deficit hyperactivity, 13 years. And for a specific phobia, 20 years. Psychotherapy is an emotionally charged, confiding interaction between trained therapists and someone who suffers from psychological difficulties. The biomedical therapies are prescribed in medical procedures that act directly on a patient's nervous system. Half of all therapies describe themselves as taking an eclectic approach in which they use techniques from various forms of therapy depending on a client's problem. Psychotherapy integration combines a selection of assorted techniques into a single coherent system. Psychoanalysis is the first formal psychotherapy to emerge, with psychoanalysis developed by Sigmund Freud. Freud's therapeutic approach of using a patient's free association, resistances, dreams, and transference, and repressed feelings and gain self in the therapist's interpretations of them to help person release repressed feelings and gain self-insight. The goal of psychoanalysis is to help people gain insight from the unconscious origins of their disorders, to work through the accompanying feelings, to take responsibility for their own growth. Psychoanalysis is long and costly. Thus, before psychoanalysis begins, the therapist often has a series of sessions to determine how appropriate the treatment may be for a client seeking assistance. Psychoanalysts seem to agree that the following 4 personal qualities are crucial to determining whether the analysis will be successful. Motivation. The person needs strong internal motivation to persist in a treatment that will require several sessions per week for several years. Capacity to form interpersonal relationships. The potential patient must have the capacity to form and maintain and ultimately detach from an intimate, trusting relationship. Capacity for introspection and insight. The therapy requires natural curiosity about oneself and the capacity for scrutiny and psychoanalysis, and must be open to painful facts and interpretations about herself, him or herself. Since psychological problems originate from the childhood, repressed impulses and conflicts are the aim of psychoanalysis, is to bring repressed feelings into the conscious awareness where the patient can deal with them. When energy devoted to the id, ego, and superego conflicts is released, the patient's anxiety will lessen. Dissatisfied with hypnosis, Freud developed the method of free association to unravel the unconscious mind and its conflicts. The patient lies on the couch and speaks about whatever comes to his or her mind, and ultimately the problem will arise. During free association, the patient edits his thoughts, resisting his or her feelings to express emotions. Such resistance becomes important in the analysis of the conflict-driven anxiety. Eventually, the patient opens up and reveals his or her innermost private thoughts, developing positive or negative feelings. Transference towards the therapist. Psychoanalysis is hard to refute because it cannot be proven or disproven. Psychoanalysis takes a long time and is very expensive. Psychoanalysis draws on these techniques such as free association, saying aloud anything that comes to mind, resistances, the defensive blocking awareness from the anxiety-laden material, and their introspection and other behaviors such as transference. Transferring the therapist of long's repressed feelings. Freud also believed that the latent content of dreams was another clue to the unconscious conflicts. Like psychoanalytic perspective on personality, psychoanalysis is criticized because its interpretations are hard to prove or disprove, and because it is time-consuming and costly. The recent challenge to repress memories on which much of psychoanalysis is built is also provoking intense debate. Today, there are relatively few traditional psychoanalysts. Most have been replaced by therapists who make a psychodynamic assumptions, that is, those who try to understand a patient's current symptoms by exploring their childhood experiences and by exploring the therapist-patient relationship. They must also help the person explore defended against thoughts and feelings. However, they talk with the patient face-to-face once a week and for only a few weeks or months. Interpersonal psychotherapy, a brief alternative to psychodynamic therapy, emphasizes symptom relief in the present, not overall personality change. The therapist also focuses on current relationships and the mastery of relationship skills. It's been found effective with depressed patients. Interpersonal psychotherapy is a variation of psychodynamic therapy. It is effective in treating depression, and it focuses on symptom relief here and now, not the overall personality change. Humanistic therapists aim to boost self-fulfillment by helping people grow in their self-awareness and self-acceptance. Developed by Carl Rogers, person-centered therapy is a form of humanistic therapy. The therapist listens to the needs of the patient in an accepting and non-judgmental way, addressing problems in a productive way and building his or her self-esteem. Humanistic therapists focus on these clients' current conscious feelings, on their taking responsibility for their own growth. In emphasizing people's inherent potential for self-fulfillment, they aim to promote growth rather than cure illness. In this client-centered therapy, Rogers used active listening to express genuineness, acceptance, and empathy. This technique, he believed, would help clients to increase their self-understanding and acceptance. The therapist interrupts only to restate and confirm the client's feelings, to accept what the client is expressing, or to seek clarification. The client-centered counselor seeks to provide psychological mirror that helps clients see themselves more clearly. The therapist engages in active listening, echoes, restates, and clarifies the patient's thinking, acknowledging expressed feeling. Behavior therapy. Traditional psychoanalysts attempt to help gain insight into their unresolved unconscious conflicts. Humanistic therapists help clients to get in touch with their feelings. In contrast, behavior therapists question the therapeutic power of increased self-awareness. They assume problem behaviors are the problems and thus do not look for inner causes. Instead, they apply learning principles to eliminate troubling behavior. So therapy that applies learning principles to elimination of unwanted behavior. To treat the phobias or sexual disorders, behavior therapists do not delve deeply into below the surface looking for inner causes. Counter conditioning is a behavior therapy procedure based on classical conditioning. that conditions new responses to stimuli that trigger unwanted behaviors. Exposure therapies treat anxieties by exposing people to things that they fear and avoid. In systematic desensitization, a prime example of exposure therapy, a pleasant, relaxed state is associated with gradually increasing anxiety triggering stimuli. This procedure is commonly used to treat phobias. Virtual reality exposure therapy equips patients with a head-mounted display unit that provides vivid simulations of feared stimuli, such as a plane's takeoff. In aversive conditioning, an unpleasant state such as nausea is associated with unwanted behavior, such as drinking alcohol. This method works in the short run, but for the long-term effectiveness, it is combined with other methods. So counter-conditioning is a procedure that conditions new responses to stimuli that trigger unwanted behaviors. It's based on the concepts of classical conditioning. It includes exposure therapy and aversive conditioning. You expose the patient to things they fear and avoid. Through repeated exposure, anxiety lessens because they habituate to the things feared. Exposure therapy involves exposing people to fear-driving objects in real or virtual environments. And oftentimes they start in the virtual environment and then eventually work up to actually experiencing the real thing. A type of exposure therapy that associates a pleasant, relaxed state with gradually increasing anxiety. Trigger stimuli are commonly used to treat phobias. And here we see the examples where first they just show a picture, and then they bring the picture closer, and they touch the picture, and then first they show the spider, and then they bring the spider closer until the person can actually touch the spider themselves. Aversive conditioning is a type of counter conditioning that associates an unpleasant state with unwanted behavior. With this technique, temporarily conditioned aversion to alcohol has been reported. Christopher Kane and his colleagues have studied fear extinction in mice, which may have important implications for the use in exposure therapy. In these techniques with repeated exposure, people became less responsive to people, objects, or situations that once petrified them. The UCLA researchers have taught mice to fear harmless white noise by associating it with a mild shock delivered to the floor of the experimental cage. After only a couple of trials, the mice froze for about 72 seconds, or 60% of the 2 minutes of white noise. The noise had come to function as the conditioned stimulus for fear. Researchers then separated the mice into 3 groups and assessed how easily they overcame the aversion to white noise when they heard it 20 times for 2 minutes, each time without shocks. The groups differed only in the intervals between each 6, 60, or 600 seconds. Unlearning a fear typically takes much longer than acquiring it. Indeed, mice feared the white noise after only 2 pairings with the shock, but needed far more than 2 exposures to overcome it. Nonetheless, Kane and his colleagues report that fear extinction occurred much more quickly when the time between stimulus and presentations was relatively short. Indeed, the 6-second gap, mice stopped showing significant freezing after about 10 presentations of white noise, while mice in other 2 groups never really stopped freezing. This is a strong finding, states co-author Mark Baran, is already inspiring a search for a similar pattern of response in human anxiety patients. It's part of the recent wave of important discoveries about fear extinction. Findings that will transform both the practice of behavior therapy and the use of drugs and adjuncts to psychotherapy in the next few years. Operant conditioning therapies are based on the premise that voluntary behavior is strongly influenced by their consequences. Behavior therapists apply operant conditioning principles by reinforcing desired behaviors while withholding reinforcement for undesired behaviors. The rewards used to modify behavior vary from attention or praise to more concrete rewards such as food. In institutional settings, therapists may create a token economy in which a patient exchanges a token of some sort earned for exhibiting their desired behavior for various privileges or treats. Critics express two concerns. First, what happens when the reinforcers stop? And might the person have become so dependent on the extrinsic rewards that the appropriate behaviors quickly disappear? Second, is it ethical for one person to control another's behavior? So operant conditioning procedures enable therapists to use behavior modification in which desired behaviors are rewarded. Undesired behaviors are either unrewarded or punished. A number of withdrawn, uncommunicative 3-year-old children with autism have been successfully trained by giving and withdrawing reinforcements for desired and undesired behaviors. A token economy is when in institutional settings, the therapist may create a token economy in which patients exchange a token of some sort, earned for exhibiting the desired behavior, for various privileges or treats. Cognitive therapy teaches people adaptive ways of thinking and acting based on the assumption that thoughts intervene between events and our emotional reactions. Aaron Beck suggests that depressed patients believe that they can never be happy and thus associate minor failings in life as major causes for their depression. Beck believes that cognitions such as "I can never be happy" need to change in order for depressed patients to recover. This change is brought about by gently questioning patients. Rabin trained depressed patients to record positive events each day and relate how they contributed to these events. Compared to other depressed patients, trained patients showed lower depression scores. Cognitive therapists assume that our thinking colors our feelings, and so they try to reach people who suffer psychological disorders new, more constructive ways of thinking. Cognitive behavior therapists combine the reversal of self-defeating thinking with efforts to modify behavior. They aim to make people aware of their irrational negative thinking, to replace it with new ways of thinking and talking, and to practice the more positive approach in everyday settings. So Aaron Peck reverses the client's catastrophic beliefs about themselves and their situations and their fears in his study. His technique is a gentle questioning that aims to help people discover their irrationalities. In stress inoculation training, people suffering depression learn to dispute their negative thoughts and to restructure their thinking in stressful situations. Still, other therapists teach depressed adults to interpret life events as non-depressed people do. For example, to take credit for their successes. So an example of this would be relax. The exam may be hard, but it'll be hard for everyone else too. I studied harder than most people. Besides, I don't need a perfect score to get a good grade. And this helps them relieve their stress. Cognitive therapists have often combined the reversal of this self-defeated thinking with efforts to modify behavior. Cognitive behavior therapy aims to alter the way people act, behavior therapy, and alter the way they think, cognitive thinking. Group therapy normally consists of 6 to 9 people attending a 90-minute session that can help more people and cost less. Clients benefit from knowing others have similar problems. Family therapy treats the family as a system. The therapy guides the family members toward a positive relationship and improved communication. The social context provided by group therapy allows people to discover that others' problems similar to their own and try out new ways of behaving. Receiving honest feedback can be very helpful and can be reassuring to find that you are not alone. Many participate in self-help and support groups for divorced people, the addicted, the bereaved, those simply seeking personal growth. Family therapy assumes that we will live and grow in a relation to others, especially our family, in an effort to heal relationships. Therapies help family members discover the role within the family's social system. In November 1995, issue of the Consumer's Reports reported survey results of effectiveness of psychotherapy. Consumer Reports 180,000 readers had been asked to fill out the mental health section of a much longer survey. If at any time over the past 3 years you had experienced stress or emotional problems for which you sought help from any of the following: friends, relatives, member of the clergy, mental health professional, like all psychologists or psychiatrists, your family doctor or support group. 22,000 readers responded to the entire survey. Of these, approximately 7,000 completed the mental health section. Of these 7,000, about 3,000 had just talked to friends, relatives, or clergy, and about 4,000 had turned to some combination of mental health professionals, family doctors, and support groups. Of the 4,000, a total of 2,900 saw a mental health professional. As a whole, respondents were well educated, predominantly middle class. About half were women. The median age of the sample was 46. Among the most important results were the following. Psychotherapy helped 9 out of 10 patients feel significantly better. Almost half, 44%, who reported their emotional health as having been poor now reported feeling good. Those in psychotherapy more than 6 months did the best. Long-term treatment was considerably more effective than short-term treatment. Psychotherapy alone did not differ from the effectiveness of medication plus psychotherapy. No specific form of psychotherapy did better than any other for any disorder. Psychologists, psychiatrists, and social workers did not differ in their effectiveness as treaters, but they all did better than marriage counselors and long-term family doctors. Martin Seligman contrasts the Consumer Reports large-scale survey study with more traditional efficacy studies in psychology in which patients are randomly assigned into specific treatment groups of fixed duration. He argues that the studies complement each other and that both contribute to our understanding of the effectiveness of psychotherapy. In more recent survey of 3,079 readers, Consumer Reports compared drug therapy with psychotherapy, focusing on disorders of depression and anxiety. The organization reported that the combination of talk therapy and drugs often proved more effective. Consumer Reports concluded that each therapy worked at a different pace, with those taking drugs showing substantial improvement within a few visits. Those who chose mostly talk therapy improved more gradually. However, talk therapy was almost as effective as the combination if it lasted for 13 or more visits. In 1995, a survey respondents averaged well over 20 visits with mental health professional. In the current survey, the average was 10 visits. A troubling trend, notes the Consumer's Report. Although drugs worked more quickly, it often took trial and error to find one that did not have unacceptable side effects. For example, 40% of those who took antidepressants complained of adverse sexual side effects. Consumer's Reports also reported that the primary care doctors were effective in treating people with mild problems, but mental health specialists produced significantly better results. For those with more serious disorders, those respondents who expressed greatest satisfaction with their care, who had the best outcomes, were more likely to research their problem before seeking help, interview with more than one professional, ask therapists if they had experiences treating their problem, bring a friend or family member along to an office visit, keep a written record of their treatment and emotional state, deliberately apply what they were learning in treatment to their daily lives. Not surprisingly, consumers reports concluded that the last step was the best predictor of the favorable outcome. Only 1% of respondents followed all these steps. 18% followed none. If you ask clients about their experiences of getting into therapy, they often overestimate its effectiveness. Critics, however, remain skeptical. Clients enter therapy in crisis, but crisis may subside over the natural course of time, regression to normalcy, and clients may need to believe that the therapy is worth the effort, and clients generally speak kindly of their therapists. From the clinician's perspective, they believe the therapy's success. They believe the client is better off after therapy than if the client had not taken part in therapy. Clinicians are aware of failures, but they believe failures are the problem of other therapists. If client seeks another clinician, the former therapist is more likely to argue that the client has developed another psychological problem, and clinicians are likely to testify to the efficacy of their therapy regardless of the outcome of treatment. Clients tend to overestimate the effectiveness of their psychotherapy because they enter the therapy in crisis. As with the normal ebb and flow of events, crisis passes, people attribute more improvement to their therapy. Clients may also need to believe that their investment of time and money has been worth it. Finally, clients generally speak positively of their therapists who are very understanding, who have helped them gain a new perspective. Research has generally not supported clients' estimates of therapy's effectiveness. Clients enter therapy when they are extremely unhappy, usually leave when they are less extremely unhappy, and stay in touch only if satisfied. Thus, therapists, like most clients, testify to therapy success. Clinicians are more aware of the therapist's failures as clients seek new therapists for recurring problems. Two phenomena that contributed to perceived value of ineffectiveness of therapy are the placebo effect, the belief that treatment will work, and regression toward the mean, the tendency of the extremes of unusual scores to fall back toward the average. Feeling low tends to be followed by or return to a more normal state, and anything we tried in the interim may seem effective. Clients and clinicians alike may have biased perceptions and hence selective and biased recall. Most people also tend to make judgments that confirm their beliefs. Carl Sable's analysis of fringe medicine supports the argument that we need to controlled research studies to assess the effectiveness of therapy. Practitioners of the fringe therapies make exorbitant claims which are simply not supported by careful research. Still, people continue to believe. A study of the U.S. Department of Health and Service indicated that 27% of U.S. adults have used one or more of these questionable health treatments. At some point in their lives, in fact, report researchers almost 1/3 of college graduates have tried at least one treatment. For example, people have used snake venom and bee venom to cure for arthritis. They've actually put bees on themselves and been stung. The practice is based on the premise that some venoms reduce inflammation. One critic suggests that people believe in it because anything feels better once the bees stop stinging. A defender of the therapy explained the practice. Bees don't get arthritis. Of course, responded the critics, bees don't have joints. Most obviously, people believe in fringe medicine because they want to. In response to this statement, when you have a serious health problem, it's worth trying almost anything. 20% strongly agreed and 24% agreed somewhat. As an example of how fringe medicine works, Saba As an example of how fringe medicine work, Sabaugh describes Emil Friedrich's tongue-in-cheek experimental plan, which enables anyone set him or herself up as a therapist is guaranteed to produce beneficial results. The plan has two essential requirements. The first is treatment of some sort. It doesn't matter what. It can be a form of psychotherapy or some physical procedure, a type of rubbing or hand waving or administration of a drug, plant, or chemical. The second requirement is the treatment be absolutely harmless. Friedrich shows that such fringe technique can lead to an outcome of confirming its success. The crucial factor is the natural viability of all disease. Every disease has important periods of remission in which the patient feels better. This is true even when there is an inexorable trend downward, guided by this principle. Friedrich recommends that treatment be applied only after a period in which the patient has been getting progressively worse. If treatment is applied during one of the ups and the patient continues to improve, he or she can always say improvement would have occurred anyway. If the treatment is applied when the patient is getting worse, then there are four possible outcomes. The patient could improve given the natural variability of the illness. Such an outcome immediately proves the treatment is effective. 2. The disease may remain stable, proving that the treatment has arrested the problem. 3. The patient may continue to get worse, which merely means the dosage was inadequate and must be increased. And 4. The patient may die. In this case, the treatment was obviously delayed too long and applied too late. When a patient improves, one must reduce the treatment. Two possible outcomes will again prove the effectiveness of the therapy. If the patient continues to improve, the treatment was obviously effective. If he or she gets worse, reducing the treatment has obviously made the disease active again. So, in randomized clinical trials, they assign people on a waiting list to therapy or no therapy. Research that includes the use of meta-analysis reveals that people who remain untreated often improve. Those who receive psychotherapy are more likely to improve. And when people seek psychological treatment, the search for other treatment declines compared to the counterparts on the waiting list. For depression, the best treatments are behavior, cognition, and interpersonal therapy. For anxiety, it would be cognition, exposure, and stress inoculation. For bulimia, it's cognitive behavior. For phobias, it's behavior modification. For bedwetting, it's behavior modification. Behavioral therapy and then behavioral modification. No one therapy has been shown to be best in all cases, nor is there any relationship between clinicians' experience, training, and supervision and licensing and their client's outcome. Some therapies are, however, well suited to a particular disorder, such as cognitive, interpersonal behavior therapies for depression, cognitive exposure and stress inoculation therapies for anxiety, cognitive behavior therapies for bulimia, and behavior modification for bedwetting. In addition, behavioral conditioning therapies achieve especially favorable results in treating phobias and marital problems, sexual disorders. Therapy is most effective when the problem is clear-cut. David Myers has described how the judgments of psychiatrists and clinical psychologists about the success of therapy may reflect common errors in thinking. Consideration of these errors not only stimulates students to think about the clinical process, but also serves to reinforce a common error made by clinicians involves illusionary correlations. Experiments conducted by Lauren and Jean Chapman found that professional clinicians perceived expected associations, for example, between particular responses to the Rorschach ink blot tests and homosexuality. Even when expected associations were absent, When we believe a relationship exists, we are more likely to notice confirming than disconfirming instances. Clinicians' judgments may also be contaminated by hindsight, bias, and overconfidence. For example, if a friend commits suicide, a common reaction is to think we should have been able to predict, therefore to prevent the suicide. In retrospect, we see the pleas for help. Thus, after a tragedy, the hindsight bias can leave therapists feeling guilty. Conversely, Lee Ross and his colleagues have shown how hindsight explanations might exaggerate a clinician's self-confidence. In one experiment, Ross had subjects read clinical case histories of people who they were told had committed suicide. They were then asked to use the case history to explain the event. Later, they were informed that there was actually no available information on how the patient's life ended. When asked to estimate the likelihood of several possible events, including the suicide, they explained suicide now seemed quite likely. The mere activity of explaining and interpreting, which clinicians are engaged in constantly, may itself contribute to overconfidence in one's judgment. The act of explaining and defending a belief enables some to understand how it might be true and thus continue to believe it even when the data that inspired it is discredited. Clients are also readily induced to give information that fulfills clinicians' expectation. In short, clinicians' judgments may reflect a self-fulfilling prophecy. Mark Snyder and William Swan found, for example, that interviewers were questioned people to see if they had a particular trait, treated them as if they had it. The question selected to test for the extroversion could not have been better calculated to elicit extroverted answers. What would you do to liven things up at a party? Similarly, people were tested for introversion were asked questions that necessarily elicited introverted answers. What factors make it hard for you to open up to people? As a result, as expected, targets being tested for extroversion described more outgoing self, and those tested for introversion revealed a more reserved self. Additional research found that those asked extroverted questions not only later perceived themselves as more extroverted, but actually became noticeably more outgoing. Comparing scientific therapies against popular therapies through electronic means, the results of such research is below. In EMDR therapy, the therapist attempts to unlock the reprocess previous frozen traumatic memories by waving a finger in front of the client's eyes. EMDR has not held up under scientific testing. In eye movement desensitization reprocessing, or EMDR therapy, the therapist waves a finger in the front of the eyes of the client to unlock and reprocess previously frozen trauma memories. Scientific testing has not supported the effectiveness of EMDR. Belief in its effectiveness may be explained in terms of the placebo effect. In contrast, light exposure therapies, or exposure to daily doses of light that mimic outdoor light, have proven effective in treating people with seasonal affective disorder, a form of depression linked to periods of decreased light, common in northern climates. Despite their differences, all therapies offer at least three benefits. First, they all offer the expectation that with commitment from the patient, things can and will get better. Secondly, every therapy offers people a possible, plausible explanation for the symptoms, an alternative way of looking at themselves and responding to their worlds. Third, regardless of their therapeutic technique, effective therapies are empathetic. The therapists are empathetic people who seek to understand another's experience, whose care and concern the client feels, and whose respectful listening, reassurance, and advice earn the client's trust and respect. In short, all therapies offer hope for demoralized people, a new perspective on one's self and the world in an empathetic, trusting, caring relationship. Psychotherapists' personal beliefs and values influence their therapy. While nearly all agree on the importance of encouraging clients' sensitivity, openness, and personal responsibility, they differ sharply on the pursuit of self-gratification, self-sacrifice, and interpersonal commitment. Value differences also become important when a client from one culture meets a therapist from another. For example, clients from a collectivist culture may have difficulty with therapists who requires them to think independently. Such differences may explain reluctance of some minorities to use mental health services. Most agree that therapists should divulge their values more openly. Clinical psychologists have PhDs. They are experts in research, assessment, and therapy, all of which is verified through supervised internship. Clinical or psychiatric social workers, they have a master's of social work. Postgraduate supervision prepares some social workers to offer psychotherapy, mostly to people with everyday personal and family problems. Counselors, pastoral counselors or abuse counselors work with problems arising from family relations, spouse and child abusers, their victims, and substance abuse. Psychiatrists, they are physicians who specialize in treatment of psychological disorders. Not all psychiatrists have extensive training in psychotherapy, but as medical doctors, they can prescribe medications. Biomedical therapies include physical, medicinal, and other forms of biological therapies, drug treatments, surgery, and electric shock therapy. Psychopharmacology is the study of drug effects on the mind and behavior, and with the advent of drugs, hospitalization in mental institutions has rapidly declined. And so most of our big improvements in medication have taken place since the 1950s. However, many patients are left homeless and on the streets due to their illness and their ill-preparedness to cope independently in outside society. To test the effectiveness of drugs, patients are tested with drug and a placebo. Two groups of patients and medical health professionals are unaware of who is taking the drug and who is taking the placebo. Psychopharmacology is the study of the effects of drugs on the mind and behavior and has revolutionized the treatment of severely disordered people. To evaluate the effects of new drugs, researchers use double-blind technique. They use the double-blind technique in which half the patients receive the drug while the other half receive a placebo. Because neither staff nor patients know who's getting this research strategy eliminates bias that results from a therapist and patient's expectations of improvement. Using this approach, several types of drugs have proven effective in treating psychological disorders. Antipsychotic drugs such as chlorpromazine, sold as Thorazine, provide help for people experiencing the positive symptoms of auditory hallucinations and paranoia and dampening their responsiveness. Irrelevant to stimuli. Clozapine, sold as Clozaril, helps reanimate schizophrenic patients with negative symptoms of apathy and withdrawal. Long-term use of the first-generation drugs, Thorazine, block D2 dopamine 2 receptors and can produce tardive dyskinesia, which is marked by involuntary movements of facial muscles, tongue, and limbs. New generation antipsychotics, such as clozapine, target the D1 dopamine receptors receptors and seem to increase the risk of obesity and diabetes. These classical antipsychotics, thorazine, remove a number of positive symptoms associated with schizophrenia, such as agitation, delusions, and hallucinations. Atypical antipsychotics, clozapine, clozaril, remove negative symptoms associated with schizophrenia, such as apathy, jumbled thoughts, concentration difficulties, and difficulties in interacting with others. Clozapine blocks receptors for the dopamine and serotonin to remove the negative symptoms of schizophrenia. Anti-anxiety drugs such as Xanax and Ativan depress the central nervous system and reduce anxiety and tension by elevating levels of gamma aminobutyric acid, the GABA neurotransmitters. Anti-anxiety drugs such as Xanax and Ativan depress the central nervous system's activity. Used in combination with other therapy, they can help people learn to cope with frightening stimuli. Anti-anxiety drugs can be both psychologically and physically addictive. Michael Scholar reports that Inderal, a heart medication known generically as propranolol, is an anti-anxiety drug for intellectuals. Unlike tranquilizers, Inderal does not cloud the mind or impair physical coordination. Professional musicians, lawyers, college students, and even physicians now take this beta blocker before important presentations or tests. The FDA has not approved Inderal specifically for anxiety, but when a drug has been approved for one condition, physicians can legally prescribe it for others. In early 1960s, beta blockers were approved to treat high blood pressure and hardening of the arteries. Patients who took the medication experienced pleasant side effects. The drugs kept them calm in stressful situations, which should not have been surprising because beta blockers reduce the symptoms that often accompany nervousness. They keep blood pressure from rising and heart from racing by blocking the chemical messengers that produce these changes. In a test of effectiveness, Inderal, professional musicians were given either a sugar pill or Inderal before performing for 3 judges and a small audience. The musicians who took the Inderal reported feeling more in control and their heart rates were slow and even. Without the drug, their heart rates were 40 beats a minute faster. More important, the judges evaluated the performances as significantly better. Inderal has been tested with high school students who freeze when they take the SAT. 25 students took the test twice using the beta blocker and the second time. Combined verbal and math scores went up an average of 120 points. Normally, a combined score goes up only 22 points. After these results were reported in the press, dozens of parents asked, calling for the name of the drug and the correct dosage so their doctors could prescribe it for their children. We could easily teach students that the only way they can face a test is to take Inderal, says Harry Fagel, who is conducting the research. It makes me wonder whether we should continue the study. Mark Seigert believes Inderal is useful for helping people whose stage fright is primarily a physical problem. Some people's bodies simply overreact to fear. He is concerned, however, that others will view the drug as a way to perform free of anxiety. He concludes that, in my experience, anxiety is something we have to live with. Recently, questions have been raised as to whether some professional golfers are using beta blockers to calm them while putting. Craig Perry, one of Australia's better golfers, stated, "I'm not trying to step on any toes. I don't want to look like an idiot. But this is a hidden part of the tour. They don't want to open Pandora's box. This needs to be fixed." The PGA Tour Commissioner Tim Finken denies the claims. Similarly, golfer Greg Norman argues golf is the cleanest sport in the world. Let's test the best players in the world. You're going to see that they're going to be negative. The argument against their use Their use, of course, is, as Craig Perry states, if you take a drug that helps calm your nerves and keeps you steadier, it's an unfair advantage. Antidepressants aim to lift people up, typically by increasing the availability of neurotransmitter norepinephrine and serotonin. For example, fluoxetine, known as Prozac, blocks the reabsorption and removal of serotonin from the synapses. Other dual-action antidepressants work by blocking reabsorption or breakdown of both norepinephrine and serotonin. Although no less effective, these dual-action drugs have more potential side effects such as dry mouth, weight gain, hypertension, or dizzy spells. Antidepressants influence neurotransmitter systems almost immediately. Their full psychological effects may take weeks. The risk of suicide for those taking these drugs has probably been overestimated. Introduced in 1987, Prozac became the world's most widely prescribed antidepressant. In the fall of 2001, it fell to third place when it lost market exclusivity to generic competition. Its cousins Zoloft and Paxil became close competitors for first place. Curiously, research suggests that these drugs show virtually no difference in effectiveness, safety, and side effects profile. Pharmaceutical commercials for the drugs increased dramatically after a September 11, 2001 terrorist attack. In fact, Pfizer, the world's largest pharmaceutical company, spent $5.6 million promoting the benefits of Zoloft in treating post-traumatic stress disorder during October 2001. In fact, antidepressants have been one of the two basic types of tricyclics or monoamine oxidase inhibitors. Both strengthen the action of the serotonin and norepinephrine, two of the chemicals that transmit impulses through the nervous system. The tricyclics work by blocking reabsorption of messengers by the nerve cells that release them. The MAOIs interfere with the enzymes that break the messengers down. Although the SSRIs, selective serotonin reuptake inhibitors, work like tricyclics, that is, they keep a neurotransmitter in circulation by blocking reabsorption, they work exclusively on serotonin, not norepinephrine. Instead of using a shotgun, you're using a bullet, observes psychiatrist James Halakis, University of Minnesota. The selective serotonin reuptake inhibitors' advantage is not that they are inherently more effective in treating depression, but rather they are easier to prescribe and have fewer side effects. They also have a broader range of uses than competing drugs. SSRIs' side effects have included headaches, nausea, insomnia, weight loss. However, these are far less serious than the low blood pressure, heart disturbances, blurred vision, and weight gain produced by older drugs. People unable to tolerate the tricyclics or MAOIs are successfully taking SSRIs. Doctors are now using drugs not only as a treatment for depression, but also to treat anxiety, obsessive compulsive disorder, and post-traumatic stress disorder. Neurologist Ruth Brune explains some people respond to one drug and not another, but most are helped by one or the other. The drugs have absolutely revolutionized treatment of disorders. The simple salt lithium is often an effective mood stabilizer for those who suffer from manic depressive swings of bipolar disorder. Although lithium significantly lowers the risk of suicide, we do not fully understand how it works. Electro-Convulsive Therapy, or ECT, is also known as shock treatment. It is used for the severely depressed patient. A brief electric current is sent through the brain of an anesthetized patient. Although ECT is credited with saving many from suicide, no one knows for sure how it works. Some patients with chronic depression have found relief through chest implant that intermittently stimulates the vagus nerve, which sends signals to the limbic system. Repetitive transcranial magnetic stimulation is performed on wide-awake patients. Magnetic energy penetrates only to the brain's surface, although the tests are underway with a higher energy field that penetrates more deeply. Unlike electro-convulsive therapy, the RTMS procedure produces no seizures, memory loss, or other side effects. Recent studies have confirmed its therapeutic side effects. In TMS, transcranial magnetic stimulation, the magnetic coil is placed over the prefrontal regions of the brain to treat depression with minimal side effects. Psychosurgery removes or destroys brain tissue in an effort to change behavior. For example, the lobotomy was once used to calm uncontrollably emotional or violent patients. The nerves that connect the frontal lobes to the emotion-controlling centers of the inner brain are cut. The lobotomy usually produces a permanently lethargic, immature, impulsive personality. Because of these effects, the introduction of drug treatments in the 1950s, the procedure was abandoned. Other psychosurgery is used only in the extreme cases. For example, for patients who suffer uncontrollable seizures, surgeons may deactivate the specific nerve clusters and cause then transmit the convulsions. MRI-guided precision surgery may also be used to cut the circuits involved in severe obsessive compulsive disorder. So psychosurgery was popular even as far back as Neolithic times, and we saw at the beginning, we saw the skulls that had trepanation in them. Although used sparingly today, only 200 such operations take place in the U.S. per year. Psychosurgery is used as a last resort, alleviating psychological disturbances. Psychosurgery is irreversible. It removes brain tissue and changes the mind. Modern methods use stereotactic neurosurgery and radiosurgery that refine older methods of psychosurgery. By 1949, when Egas Moines won a Nobel Prize for developing the lobotomy, a type of psychosurgery, tens of thousands had been lobotomized. Alcohol abusers, criminals, retarded people, including Rosemary Kennedy, sister of President John F. Kennedy. During the 1950s, calming drugs became available and psychosurgery was largely abandoned. For the most part, psychosurgery has become taboo, even though refinements targeting very limited area of the brain are now much safer. Neurosurgeons perform operations at the risk of being picketed. Students may be interested in that Moines himself was shot and left partially paralyzed by one of his lobotomized patients. One notable exception is a procedure known as cingulotomy, which has been performed at Massachusetts General Hospital. Bearing little relation to the lobotomy, the procedure involves passing an electrode needle through two small holes in the skull, searing a tiny lesion in the cingulum, a bundle of nerve fibers linking the emotional centers of the brain with the thought centers in the cortex. Since 1962, about 700 patients have received cingulotomies, averaging about 20 operations annually. Used primarily in the treatment of obsessive compulsive disorder, certain phobias, and depression, the surgery is offered only to those who have been ill for years and in many cases are at risk for suicide. In addition, patients must provide therapy and drug treatment. No surgery is ever performed without the patient's informed consent. Although case reports indicate extraordinary turnarounds for some very sick people, Experts do agree on the overall success rate of this surgery. Chief Surgeon G. Reeves Cosgrove puts the improvement rate as high as 60 to 70% for depression, somewhat less for obsessive compulsive disorder. All agree, however, that the procedure is relatively benign, causing none of the disastrous side effects associated with lobotomies. A new surgical tool called a gamma knife permits the procedure to be performed without piercing the skull. It shoots hundreds of beams of radiation through the angles at the target side of the brain. Although no single beam damages the tissue where the beams converge, a lesion is created. Preventing psychological disorders means removing the factors that affect society. Those factors may be poverty, meaningless work, constant criticism, unemployment, and racism and sexism. Preventative mental health experts view many of these psychological disorders as understandable response to a disturbing, stressful society. It's not only the person who needs treatment, but also the person's social context. Thus, the aim of preventative medical health treatments is to change oppressive, esteem-destroying environments into a more benevolent, maturing environments that foster individual growth and self-confidence. Clearly, a human being is an integrated biopsychosocial system. For example, stress affects the body, chemistry, and the health. Effective treatment requires biological, psychological, and social cultural factors. Emdr Cohen, a professor of psychology at the psychiatry at the University of Rochester and the director of University Center of Community Study, believes we must replace the pervasive disease model in psychology with a wellness model. We must shift from emphasizing people's weakness to shoring up their strengths. The task will not be easy. He suggests for even the mental health field simply and naturally thinks sick more and long before it thinks well. 4 specific concepts currently being researched and tested in programs such as Head Start and Perry Preschool Project, which target inner-city children from high-risk families, and illustrate what Cohen means by new emphasis on wellness. The first is teaching competence. The term refers to both practical skills such as necessary to do a job well and social skills, for example, the ability to communicate and control anger. The presence of these skills, says Cohen, relates to wellness and their absence to maladaptation. Although acquiring competence is lifelong, the best time to lay the foundation is childhood. Another concept is resilience, or the ability to withstand pressure and emerge stronger for it. Cohen advocates examining in greater detail youngsters who live in the chronic shadow of what psychologist Norman Gamsey so aptly called stressors of marked gravity. Studying those thrive in this environment could help others living under chronically stressful conditions. 2 socially oriented concepts are also important in the Cohen model of wellness. One is a social system modification that is helping foster environments that promote wellness. Institutions such as schools, churches, and workplace are especially important to target because they are rarely neutral in their impact on people, whereas some act coincidentally to enhance wellness. Others, oblivious to incidental outcome effects, may pose unintended obstacles to wellness. The other social concept is empowerment. For many people, the roots of maladaptation or problems in living reside less in personal failings than in de facto aspects of the macro system that deprive them of power, justice, and opportunity. A major goal, then, is to promote policies and conditions that enable people to gain control over their lives on the assumption that this will reduce problems in living and enhance wellness. This concludes Chapter 17 on therapy in AP Psychology.